Hello, my name is Alex Beggs, and I will be covering hypertriglyceridemia. We will chat very briefly about lipid physiology. We will classify triglyceride levels and the risks associated with those levels. We will talk about risk factors for hypertriglyceridemia, and we will discuss a case study and then talk about some treatments, some pharmacological and non-pharmacological treatments of hypertriglyceridemia. We should all be vaguely familiar with the image located on the slide regarding the exogenous and endogenous pathways of lipid transport from Advanced Pathophysiology with Dr. Harris. Obviously, we're focusing on triglycerides in this presentation, so I'm just going to do a quick little overview. Plasma triglycerides are composed of two distinct classes of lipoproteins, chylomicrons and very low density lipoproteins, or VLDL. Dietary triglycerides are uptaken in the intestines by chylomicrons. They travel through the peripheral vasculature. Some triglycerides are delivered to the peripheral tissues, chiefly skeletal muscle and adipose tissues. The chylomicron fragments, which are composed of triglycerides and cholesterol, are then endocytosed by the liver. The VLDL, or very low density lipoproteins, are created in the liver from 1, the chylomicron fragment triglycerides, and 2, excess carbohydrates that are synthesized into triglycerides in the liver. Triglycerides are packaged within the VLDL with cholesterol. They are released into the serum, into the peripheral vasculature, where triglycerides are delivered to peripheral tissues. The VLDL are the majority triglycerides and the minority cholesterol. Once the triglycerides from VLDL are given to the peripheral tissues, they are then intermediate density lipoproteins, which are mostly cholesterol with very little triglycerides left. Some of the IDL is taken up by receptors on the liver and kind of recycled, and the remainder of the IDL continues to circulate in the peripheral vasculature, delivering what triglycerides they have left. Once the IDL is devoid of triglycerides, it's then considered LDLC, low density lipoprotein cholesterol. That's because it has only cholesterol and no triglycerides left. That was a quick little overview. Some things to think about. Chylomicrons deliver triglycerides to peripheral tissues and then are rapidly disappear. They're rapidly taken up by the liver and endocytosed. Soon after the majority of the fat is delivered to the tissues. However, if we look at fasting levels of triglycerides between 500 and 1,000 milligrams per deciliter, the clearance of chylomicrons from the blood serum is significantly slower at those levels. Chylomicrons from the previous night's meal are still circulating the following morning. This contributes to higher accumulation of triglycerides from dietary fat, kind of a backed up system, if you will. And then we can again mention that triglycerides in the liver that are synthesized in the liver are mainly from excess carbohydrate intake that is biotransformed into triglycerides. Classification of triglyceride levels. There's a little bit of a debate in the medical community on the 4 classifications, whether it should really be 3 classifications, but so a normal triglyceride level, serum level, is going to be less than 150 milligrams per deciliter. A borderline is going to be 150 to 199 milligrams per deciliter. A high level serum level is going to be 200 to 499 milligrams per deciliter. And a very high serum level will be greater than 500 milligrams per deciliter of triglycerides. There's a little bit of debate whether borderline should be eliminated or not. When looking at that, there is a mild to moderate risk of cardiovascular disease with triglyceride serum levels greater than 200 milligrams per deciliter, and that is a cardiovascular disease risk factor independent of cholesterol. So if you have elevated cholesterol as well, that's even more significant risk for cardiovascular disease. When thinking about that as well, we think about a co-diagnosis with diabetes that increases your risk for cardiovascular disease from a mild moderate to a moderate significant, especially if they also have elevated cholesterol levels. So that's definitely a consideration when thinking about treating high triglyceride levels. Another thing to think about, a risk, is pancreatitis. The evidence is a little bit back and forth. It seems as though there's a moderate risk for pancreatitis at greater than 500 milligrams per deciliter, but the significant risk is above 900 and 1,000-ish milligrams per deciliter of serum triglycerides. The reason for this is the backup of the chylomicrons. They're triglyceride rich. They're large enough to occlude the pancreatic capillaries, leading to ischemia and subsequent structural alteration of the SNRs, causing the release of pancreatic lipase. So obviously, if you have somebody with high triglycerides, very high triglycerides, chiefly even if they don't have diabetes and they only kind of have a mild to moderate risk of cardiovascular disease, we still want to think about their risk for pancreatitis and limiting that. Some epidemiology and risk factor information for hypertriglyceridemia. Excuse me. Approximately 31% of the U.S. adult population has a triglyceride level greater than 150 micrograms per deciliter. That means that they are at least borderline high, if not high or very high, putting them at different risk stratification levels for cardiovascular disease and, of course, pancreatitis as well. Triglycerides have been identified in several studies as an independent cardiovascular risk of cholesterol. So it's important that if we have somebody who has very high triglycerides, sometimes even high triglycerides, that we are pharmacologically treating them as well as doing some lifestyle modifications to reduce their risk of cardiovascular disease and pancreatitis. Hypertriglyceridemia can be primary or secondary in nature, so that's pretty important when doing your differentials, thinking about not only secondary causes, but also primary causes, which are only about 5% of hypertriglyceridemias, but so it'll be pretty low on your differential list. Some risk factors for secondary hypertriglyceridemia are going to be alcohol intake, high fat or high carb diets. To go along with that, diabetes mellitus and metabolic syndrome, as well as obesity. A lot of these are usually sometimes related, although not always. We think about excess intake of fats, maybe saturated fats, and high intake of carbohydrates. As we discussed earlier, the excess saturated fats, so triglycerides included in there, are going to be delivered to peripheral tissues, chiefly to adipose tissues. The chylomicrons are going to have difficulty keeping up with delivery to tissues and are going to get pretty backed up, increasing the serum level of triglycerides. Also, the excess of intake of carbohydrates are going to be synthesized into triglycerides in the liver, packaged in the VLDL, and released into the serum, trying to deliver triglycerides to peripheral tissues, somewhat in competition with the chylomicrons. So you can see how that's kind of a double whammy. Another thing to think about is the alcohol intake. There are several studies that indicate that obese subjects appear to be more susceptible to hyperlipidemic effects of alcohol than non-obese subjects. So if you have somebody who's non-obese, if you have somebody who's not diabetic, think about alcohol intake as the cause of their hyperlipidemia. Hypertriglyceridemia in this case. There are some metabolic studies that show that the increased transport of VLDL triglycerides in overweight patients is associated with delayed clearance of chylomicron triglycerides, as we talked about earlier. Another one is hypothyroidism, is another cause of hypertriglyceridemia, kind of a decreased metabolism of of the lipoproteins and the delivery of the triglycerides. So again, the higher serum level. So that's always a thought as well. So if you have no identifiable secondary causes of your hypertriglyceridemia, then you want to consider maybe a primary hypertriglyceridemia. They call them the Fredrickson's classifications. There's the Fredrickson's 1 through 5, a variety of different genetic mutations. So obviously these are low on your differential, but if there's no identifiable secondary cause, then maybe refer them to a genomic specialist and figure out if you have a primary hypertriglyceridemia. We have a 56-year-old Caucasian male presenting for a routine blood pressure and lipid screening follow-up. He has no chief complaint. He has a medical history of hypertension, hypertriglyceridemia, and seasonal allergies. He has a drug allergy to penicillin, which caused a rash. His current medications are lisinopril 10 milligrams PO once daily, loratadine 10 milligrams PO once daily, and he was previously on Trilipix, which is a fenofibrate, and he stopped taking that due to cost. Social history, he lives at home with his wife and teenage child. He works full-time as an accountant. He denies any smoking history, reports 5 to 6 beers per night, denies illicit drug use, and reports feeling safe at home. I would address the 5 to 6 beers per night with a cage assessment, find out if it's the drinking is interfering with his home life, his work life, etc. Family history is significant. Mother with high cholesterol, hypertension, chronic pancreatitis. Excuse me. Father with hypertension, diabetes mellitus type 2, coronary artery disease, MI, and deceased from a cerebral vascular accident. Sister with diabetes mellitus type 2 and high cholesterol, and a maternal grandmother with a history of chronic pancreatitis, deceased from pancreatic cancer. So aside from the cage assessment of the alcohol intake, I would also kind of consider family history. There seems to be a history of pancreatitis, chronic pancreatitis, as well as diabetes, cardiovascular disease, kind of several risk factors there that I'll take into consideration as going forward. Review of systems, denies fever, chills, night sweats, weakness, fatigue, denies changing in hearing, vision, or headaches, denies chest pain, shortness of breath, diaphoresis, syncope, and intermittent claudication, denies cough, shortness of breath, paroxysmal nocturnal dyspnea, denies nausea, vomiting, diarrhea, constipation, denies abdominal pain, denies any changes in skin color, texture, or presence of any lesions, denies weakness, changes in gait, or memory. Pretty benign review of systems. Moving on. Physical exam. Vitals 36.8 Celsius, 138/78, 18 respirations, 82 pulse, 99% on room air, BMI is 30. Patient is alert oriented, speech is clear and appropriate. Patient is well groomed, in no apparent distress. Normocephalic, atraumatic. Sclera is white and non-icteric. Conjunctiva is clear. Regular rate and rhythm, S1, S2 appreciated. No murmurs, rubs, or gallops to auscultation. 2+ peripheral pulses. Ankle brachial index is normal. No jugular venous distension. Clear to auscultation bilaterally. Symmetric chest excursion. Abdomen is non-tender, non-distended. Bowel sounds in all 4 quadrants. No renal or aortic buries appreciated. Skin is warm, dry, and grossly intact. Cranial nerves 2 through 12 are intact with no focal neurological deficits. Taking a look at laboratory values, We have a normal TSH and T4. We can rule out hypothyroidism. Triglycerides are elevated at very high classification, 982. Total cholesterol is slightly elevated. LDL is slightly elevated. HDL is on the lower side. Fasting glucose of 115, that is pre-diabetic, and a UA is negative for proteins. So there's some considerations here. I did do a ASCVD risk estimator for cerebral vascular disease risk calculation, 10-year risk, 15.3%, which is pretty significant. That's with male gender, 56 years of age, white, Caucasian, total cholesterol 232, HDL of 28, systolic blood pressure of 138, is receiving treatment for hypertension, is not currently diabetic, although he is pre-diabetic, and is a non-smoker. So that gives us our 15.3% risk. So we'll be addressing that in a few slides from now. The previous recording on this inappropriately identified the ASCVD as cerebral vascular disease. That was a mess up of mine. I meant to say cardiovascular disease. So clinical reasoning in our differential diagnosis, this is most probably related to the alcohol and diet intake of the patient, the 5 to 6 beers per night, and in talking with the patient more, their diet is a high carbohydrate, high saturated fat diet, which will be addressed later on. We're also considering a metabolic syndrome here. Their glucose was pre-diabetic. They have a waist measurement of greater than 35 inches. Their triglycerides are greater than 150 milligrams per deciliter. Their HDL is less than 50 milligrams per deciliter. Their systolic blood pressure is greater than 130. And their fasting blood sugar is greater than 100, meeting all the 5 criteria for metabolic syndrome. So kind of a mixture of alcohol diet and the metabolic syndrome here, pre-diabetes. So doing some education will definitely be down the road. We did rule out hypothyroidism as a cause, as our T4 and TSH levels were normal. We did rule out nephrotic syndrome with the UA was negative for proteins, and there was no symptomatology to go along with either the hypothyroidism or the nephrotic syndrome. Drug-induced hypertriglyceridemia, I ruled out. I don't know that we talked about that earlier, but there are some drugs that can cause a secondary hypertriglyceridemia, including tamoxifen, some immunosuppressants, some glucocorticoids, thiazide diuretics, protease inhibitors, and some beta blockers. On the bottom of my differential is primary hypertriglyceridemia, just because it's always there as kind of a backup, kind of a distant differential that we haven't really ruled out, even though it's unlikely. This is the treatment algorithm for the management of hypertriglyceridemia through the American Academy of Family Physicians. There are a variety of bodies that release treatment algorithms for hypertriglyceridemia that may vary slightly. This one focuses mostly on lifestyle changes for people with borderline high triglycerides. People with high triglycerides, majority are therapeutic lifestyle changes, and depending on their LDL and their ASCVD risk, statins and possibly fibrates, depending on their kind of cholesterol and triglyceride levels. And then the very high triglyceride levels, the greater than 500, are pretty much definitely getting pharmacological intervention for the triglyceride levels, as well as some significant therapeutic lifestyle changes. So you can take a look at that flow sheet and kind of get an idea of what you would do in these cases. When considering treatments for hypertriglyceridemia, we can always consider therapeutic lifestyle changes for patients with borderline high or very high triglyceride levels. These therapeutic lifestyle changes include reducing saturated fat and total fat intake, limiting alcohol intake and carbohydrate intake, and achieving glycemic control for diabetics and those with metabolic syndrome. Some more things we can do is encourage exercise, regular exercise, and smoking cessation, as these will help to lower triglycerides and raise HDL concurrently. Fibrates are really the mainstay of therapy for high triglycerides. They reduce plasma triglycerides by up to 50% and raise the high density lipoprotein, the HDL cholesterol, by about 20%. They are the only treatment for high triglycerides that are associated with a decreased risk for cardiovascular events, although I don't believe they reduce mortality. Omega-3 fatty acids are an adjunct therapy that can be thrown in to reduce plasma triglycerides by an extra 20% on top of the other therapy. They have been used in the reduction of recurrent pancreatitis as well, so through some protective factors. So that's always a consideration if you have somebody with a history of pancreatitis and they have high triglycerides. Omega fatty 3 acids might be a good choice as well. Niacin, as I understand, has quite a few side effects. The studies don't show that it lowers cardiovascular event risk or mortality. It only mildly increases HDL and mildly reduces triglycerides and LDL, so it's really not the best choice with the other therapies that we have, although I'm sure it has its place. Some kind of a novel thing that we have now is plasmapheresis, and that's really for someone with really extreme levels of triglycerides, probably the primary hypertriglyceridemia person, with levels like 2,000 or so, and I believe Dr. Babarak is the only one around who does the plasmapheresis for lipids, but that's always something to think about if your lipids are through the roof when thinking about treatments. So the next slide we'll go on and talk about the what we chose for treatments. So we talked to George about therapeutic lifestyle changes. He's going to work on reducing his alcohol intake, watching and counting his carbs, reducing his sugar intake, and replacing saturated fat with unsaturated fats. He's going to try and exercise 3 to 4 times a week for about 20 minutes each time, and try and work on losing a little bit of weight and reducing his BMI, reducing his waist size, and we're going to continue to monitor his glucose levels and his other vital signs. I chose fenofibrate since the fibrates are the mainstay of therapy. They modulate peroxisome proliferator activated receptors in the liver with decreased hepatic secretion of VLDL and increased lipolysis of the plasma triglycerides. They also reduce small density lipoproteins and increase HDL. Fibrates are well absorbed in the GI tract, especially when taken with food. They are converted to fenofibric acid and are about 98% protein bound. They are hepatically metabolized by the CYP3A4 enzyme, and fenofibric acid is eliminated with a half-life of about 20 hours, allowing for a once daily dosing. All members of this class are primarily excreted via the kidneys, and some display increase in plasma half-life in individuals with severe renal impairment. So GFR and creatinine needs to be looked at with these medications to kind of decide dosing and the likes. The long-acting forms of the fibrates have pharmacokinetic properties similar to those of immediate acting. The long-acting forms have increased oral bioavailability with less variability in absorption compared with the intermediate acting forms of fenofibrate, so those are always considerations when choosing a fibrate. This is part 2 to the audio to this slide. Sorry about splitting that up. So when we talk about fibrates and their metabolizing pathway through the CYP3A4 enzyme, we have to think of some drug interactions that could that share a high degree of binding to albumin and are metabolized by this pathway. We think of warfarin, cyclosporine A, and some oral hypoglycemic agents, including metformin and glyburide. So those are some important medications to note for interactions with the fibrates. Also, another important thing to think about are statins: lovastatin, simvastatin, pravastatin, and fluvastatin. There is a risk for hepatotoxicity and myopathy, kind of potentiating each other with these two therapies, and it's something to really consider when treating a patient, especially, for example, this patient, George. He really has some pretty high triglycerides. He has his risk for pancreatitis. He has risk for cardiovascular disease, cardiovascular events. His 10-year ASCVD risk is 15.3%, so he really should be on a statin. He should also be on a fibrate. So in this case, it's kind of weighing pros and cons, talking to the patient about risks of not being on either med, on being on each med, kind of the risk of pancreatitis versus the risk of cardiovascular events, and then talking about co-treatment and the monitoring that would need to take place if he was placed on both of these medications. Probably every 3 months he would need LFTs and monitoring for symptoms of muscle weakness, tenderness, kind of fatigue, and because of the risk of the myopathy and hepatotoxicity. But considering his unique situation where he is really at a high risk for cardiovascular events and pancreatitis, I think it's really important for him to be on a statin as well as a fibrate. I don't know if Jeff would agree with me. I hope he'll let me know if he doesn't, but I would put him on fenofibrate, generic, because he was previously on Trilipics, which he could not afford. I looked on UpToDate and it's quite expensive, but the generic version of fenofibrate is about $28 for a month, so it's significantly less expensive. And then simvastatin, I would also put him on a low dose to reduce his risk of CVD.